Welcome to our presentation. Our topic is multifaceted podiatric intervention including footwear to prevent falls in older people. The chosen eye to address this topic is effectiveness of a multifaceted podiatry intervention to prevent falls in common dwelling older people with disabling foot pain, randomized controlled trial. The objective of the study is to determine the effectiveness of a multifaceted podiatry intervention in preventing falls in older people who have disabling foot pain. Recent findings, foot problems, which 1 in 3 elderly are inflicted with, have now been associated with falls. Given the lack of guidelines that specify assessments and interventions for falls, La Trobe University conducted a study using 350 community-dwelling men and women, all with disabling foot pain and an increased risk of falling. 153 allocated to a multifaceted podiatry intervention, the remaining 152 allocated to routine podiatry care with 12 months of follow-up. Multifaceted intervention consists of foot orthosis, advice on footwear, subsidy for footwear, foot and ankle exercises, a falls prevention booklet, and routine podiatry care for 12 months. The control group received standard routine podiatry care, designed as a randomized control trial, measured the proportion of fallers and multiple fallers, falling rate and injuries from falls to differentiate the intervention and control groups. All of this was conducted at the La Trobe University Health Science Clinic in Melbourne, Australia.
So our PICO question is, the population would be the older people. We've chosen it to be greater than 65 years of age. The intervention would be multifaceted podiatric intervention, including footwear. Comparison, we didn't choose one. Outcome would be preventing falls. And the research question is the use of multifaceted podiatric intervention, including footwear, effective in preventing falls in older people? So here's our search strategy. And we've chosen to use the TRIP, Cochrane, and CNAIL database. So for TRIP database, we use a PICO mnemonic function available on the website. So P will be older people, I will be podiatric intervention, O will be preventing falls, and a total of 29 results were shown. Of the 23 results were irrelevant to the research question and were considered as having low levels of evidence. Therefore, 6 relevant studies were considered. Of the 6 studies, 1 study had the highest level of evidence due to being a randomized controlled trial. So that article was effectiveness of a multifaceted podiatry intervention to prevent falls in common dwelling older people with disabling foot pain, and as marked as the black arrow. So Cochrane Library, we used a search function. So S1 was podiatric interventions, search 2 was prevent falls, and S3 was the combination of S1 and S2. Total results was 3, and 2 of the 3 studies were cohort randomized studies, which are not the highest level of evidence, thus excluded from the critical appraisal. Whereas the article by Men's Older People Perceptions of a Multifaceted Podiatric Medical Intervention to Prevent Falls was also found on the TRIP database and considered as having a lower level of evidence compared to the article by Spink, hence also excluded from the appraisal process. So for CNAIL, we utilized a similar search strategy. Following limiters were used: English language, published data, 2007 to 2017, human age group 65 plus or greater than 80. And that limited 15 studies to 2 studies. Again, the study by Spink MJ was found to be the highest of the 2. So as shown, the results were limited from 15 to 2. And the same article as TRIP was found to be the highest level of evidence. So we decided to use the article by Spink according to the Oxford Center for Evidence-Based Medicine 2011 levels of evidence, and this question was considered to be a treatment benefits question. So for a critical appraisal, we decided to use Pedro scale in assessing the quality of the study. So the first eligibility criteria was specified. Participants were eligible if they were community dwelling, age 65 years or over, were cognitively intact, reported disabling foot pain, increased risk of falling, and a exclusion criteria was also included. And secondly, subjects were randomly allocated to groups via telephone service provided by National Health and Medical Research Council Clinical Trial Center to carry out the randomization process. Allocation was not concealed due to the nature of intervention, since participants in treatment groups received an intervention package. The groups were similar at baseline as illustrated in Table 1, baseline characteristics of participants in intervention. Participants were not blinded due to their knowledge of the group allocations. Therapists administering the intervention was not blinded. A podiatrist involved in the study administered the intervention to treatment groups. Assessors were blinded to the measurements of key outcomes due to blinding of group allocation. Key outcome was obtained from more than 85% of the studies initially allocated to groups. 91% of the results obtained from 6 months assessment, 97% of results obtained from the 12-month follow-up. All analyses were carried out using the intention to treat principle, thus intention to treat was achieved. Between group and statistical comparison was included for key outcomes. The study results reported p-values, relative risk, and incidence rate ratio. The study also provided point measures and measures of variability for key outcomes such as mean, standard deviations, and confidence intervals. And the total Pedro score was 7 out of 10. The reason why it's out of 10 is because the first criteria is not included in the Pedro score. And the biases in the study. So the first bias would be selection bias, which is defined as the systematic differences between individuals selected for studies and those who are not. And the sample participants were derived from assessing podiatry services at La Trobe University Health Science Clinic and advertisements in the local newspaper and on radio. Thus, the sample is not representative of the wider population. As participants who have increased interest in commitment in the intervention, however, selection bias was controlled for with the use of the eligibility criteria. The second bias evident was allocation bias, which refers to the intervention and control groups being systematically different due to the way they were put into groups. So allocation bias was indeed minimized through the use of interactive voice response telephone service to carry out randomization with mixed block lengths of 4 and 6 participants. This randomization technique will evenly distribute both groups to have similar baseline characteristics. Ascertainment bias is when the results or conclusions of the study is distorted by the knowledge of which intervention each participant is receiving. And this was evident due to the lack of blinding of participants, and with the lack of blinding, they will have knowledge of group allocations and participants will have ability to distort their results. Assessment bias refers to the assessor's lack of objectivity during assessment of participants, thus resulting in possible distortion of outcomes measured. And this was evident when, because this was minimized because the participants were blinded to the allocation process, and data falling rate were collected via self-reports by monthly 4 calendars, which controls assessment bias since assessors will not be involved in measuring the key outcomes.
Okay, so the main outcomes measured for this study in the 12 months after baseline assessment were proportion of fallers, proportion of multiple fallers, falling rate, and injuries. In total, 264 falls occurred. Intervention group had 103 falls, whereas control group had 161 total falls. According to the results, there is a trend in greater proportion of fallers and multiple fallers in the control group compared to the intervention group. However, the proportion of fallers and multiple fallers between groups did not differ significantly. Single fallers had a relative risk of 0.85 and a 95% confidence interval ranging from 0.66 to 1.08, and a p-value of 0.19, which was not statistically significant. Multiple fallers, relative risk of 0.63 with 95% confidence interval from 0.38 to 1.04, and a p-value of 0.07, which is greater than the set value of less than 0.05. Overall, 8 participants' falls resulted in fractures. Intervention group 1 fall and control group had 7 falls with relative risk of 0.14 and a 95% confidence interval from 0.02 to 1.15. However, the difference between amount of injury occurrences between groups was not statistically significant, with a p-value of 0.07. Mean range of falls per participant, intervention group was 0.67, whereas control group was 1.06. Participants in the intervention group experienced 36% fewer falls than participants in control group. Incidence ratio of 0.64 between groups with 95% confidence interval ranging from 0.45 to 0.91. Difference is statistically significant as the p-value was 0.01. The trend of the multifaceted podiatry intervention reducing the proportion and rate of falls and injury risks may also be mediated by the secondary outcome measures. Statistically significant improvements in areas of strength, range of motion, balance, and functional ability. And yeah.
As part of the study, we looked at the potential risk, benefits, and cost of the intervention. Potential risk we looked were the participants' indoor footwear. The study consisted of footwear orthosis and footwear for reduction of falling. However, the footwear which we assessed were outdoor footwear and not indoor. It has been reported previously that the selection of indoor footwear by elderly people is primarily influenced by comfort and low cost. Due to this reason, it could be a possible reason that indoor footwear could contribute to the risk of falling. After analyzing the risk, we moved on to analyze the benefits. As stated before, there was a reduction in falls in older people, which was the outcome we desired. Due to the positive result of reduction in falls, we stated that the intervention was an effective falls prevention in older people and that it be incorporated in podiatry practice and other multidisciplinary. Other benefit was the exercise that were used for the risk of falling of the intervention. The exercise was simple and able to be executed by elderly people. There was high rate of compliance with the exercise which were asked to be performed as part of the intervention. There were only 3 exercises which were to be completed on a weekly basis. The intensity of the exercise weren't difficult as none of the participants reported any adverse events during the trial. The home-based exercise program is feasible for older people to undertake. It requires simple and inexpensive equipment, and it can easily be explained to participants with the assistance of a booklet and accompanying DVD. The next topic we considered was the cost of the intervention. Cost of intervention was inexpensive and relatively simple to implement. The foot orthoses used were prefabricated, so do not require the time consuming, and the cost for casting was low. As a group, we recommended that this intervention should be used as the results were proved that there was a decrease in falls in elderly people. As reported by participants, they did not report any adverse effects during the trial. And after comparing the benefits, risk, and cost of intervention, we highly recommend that this intervention should be used in podiatry practice. These were the references we used for our PowerPoint. Thank you for listening to our PowerPoint.